Hello, this is Teen Care, NUR 610 Group QN-7. Our group members are Meredith Rowland, Andrew Spears, Elizabeth Watts, Jennifer Wigington, and Christy Whitesong. And our team focused on end-of-life care for this project. So now I'm going to tell you a little bit about the organization that we have formed with our group. This is a hospice organization that will be focusing on end-stage heart failure patients. That's the primary clients that we serve. For these clients, just a few key things that we want to make sure we cover for every patient will be providing comfort measures in their final days or weeks of life, serving clients in their own homes as well as in skilled nursing facilities, serving patients in urban and rural areas within a 50-mile radius of the Birmingham, Alabama area. So this could be the county surrounding Jefferson County also. We'll also be providing a patient and family-centered interdisciplinary approach and working with multiple disciplines together to provide the best patient outcomes. Our team will consist of a palliative care physician, nurse practitioners, hospice nurses, and case managers. We'll also have nursing assistants and pastoral care as well. A nursing team leader will be our person that is kind of designated to kind of keep every case together so everybody's on the same page, and they're going to lead a weekly interdisciplinary patient collaboration meeting to ensure that the best practice methods are in place. And no decisions will be made altering patient care without a collaboration session first. So as with any organization, as we've learned from this class, you have to use a systems approach and define what each system is going to be. And each system is really interrelated to each other in some way. So for our organization, the microsystem will consist of a client served and any employee or agent directly employed by Teen Care. Our mesosystem will be any person indirectly involved with Teen Care's organization, including the pharmacy that the patient gets their prescriptions filled out, any medical supply companies that will provide like durable medical equipment such as bedside commodes, hospital beds, those kind of things, family members that work together with us to take care of their loved one, and any friends of the patient that may have a significant impact on the care, such as people from church that may come visit and sit with them, or just like their next door neighbor. And as the whole, the macrosystem, this will be the patient's primary care physician, their cardiologist or referring physician, their hospital of choice, their private insurance, or their Medicare as well. So now I'm going to tell you about the demographics of the patient population that Teen Care will serve. Patients with end-stage heart failure, obviously, male or female, approximately age 65 and older, but we will accept younger as well, because we all know that there are younger people that have heart failure for various reasons. They can be any ethnicity or socioeconomic background. Most of them will be from an urban or rural area, as long as it's within a 50-mile radius of the Birmingham, Alabama area. The qualifications they must meet before they're admitted to hospice: the patient has to have received a terminal diagnosis with a life expectancy of 6 months or less, and the patient must not seek any treatment for the terminal condition as far as like life-prolonging measures. They must realize that we're going to provide comfort measures, things to make them have a peaceful end of life. The patient must show a steady decline in health over the previous few months, and if the patient lives longer than 6 months, then they're able to stay on hospice as long as they still meet these qualifications. If their health improves, they can be discharged from the hospice program as well. So now I'm going to give you some statistics about heart failure and how it affects the United States and the healthcare system. There's over 5 million Americans who have some form of diagnosis of congestive heart failure. 10% of them are in the advanced stages of the disease process. There's 400,000 to 700,000 new diagnoses of heart failure every year, and the southern U.S. has the most deaths from heart failure when compared to other regions of the United States. Heart failure can cause some signs and symptoms that are very uncomfortable for the patient, such as shortness of breath, chest pain, kidney failure, cirrhosis of the liver, coughing, pulmonary edema, and swelling or edema in the lower and other extremities as well. Heart failure is a very expensive disease. It costs the healthcare system $32 billion annually. And once a patient receives a diagnosis of congestive heart failure, they usually won't live any longer than 5 years after receiving the diagnosis. But as we all know, there are some exceptions to the rule, but that's just a general rule. So there's kind of a stigma that comes along with palliative care and a lot of elderly people and even young people as well. They usually don't understand the purpose of the palliative care, which can lead to a delay in the appropriate care and relief of the symptoms. Heart failure is very unpredictable in the nature and can make decision-making difficult when choosing between life-sustaining measures or relief measures of their symptoms. I work in the coronary care unit at UAB Hospital, so we treat many of these types of patients, and usually they really don't have very good of understanding between life-sustaining treatment and the palliative relief of their symptoms. They feel like if you tell them that they're doing palliative care, that they're pretty much giving up and wanting to pass away, even if they may not be. And a lot of times they don't realize that they may quantity have a lot more months, but the quality of it may not be quite as well. So it's very important to educate these people on the differences between the two types of care. So now I'm going to talk about who all the team members are going to be of our organization. And as you'll see in just a couple slides, we're basing this off a number of 75 patients to enroll to start with as being our base startup. So we're going to have one palliative care physician who will serve as the medical director also, 2 nurse practitioners, 10 staff nurses, 8 CNAs, 3 team leaders that will manage all of these cases and keep the plans of care all together, 2 case managers, as well as 2 chaplains. And we'll increase the number of staff as the number of enrollees increase in our organization. The advanced practice nurse or the nurse practitioners, they play a crucial role in the organization by determining if clients meet the criteria for hospice admission, as well as completing admission documentation and formulating a plan of care in collaboration with the palliative care physician. So now I'm going to talk about the financial plans of our organization and the primary forms of payment we'll accept and things like that. So primarily we are going to accept 4 payments for services rendered, which are Medicare, Medicaid, private insurance, as well as self-pay. Patients participating in self-pay, they must show the ability to pay before enrolling in the program. Not to try to discriminate against anyone, but if you're not able to pay for the services, then we won't be able to enroll those people because, as we know, it is a business and we still have people that we have to pay. The case manager will work closely with all the patients to ensure they're receiving their full benefits to which they are entitled. So, say we have somebody that is quote-unquote self-pay, but really they're indigent, we'll work with the case manager to see if maybe they can qualify for some type of Medicare or Medicaid kind of insurance. So now I'm going to talk about the total operating budget of TeamCare. The estimated budget is going to be $1,763,680. This number that we've got is based on a payment of $156 a day. That right now is the current guideline from the Medicare services. So we expect private insurances to pay about the same as well as Medicaid. And this will be the rate that we charge self-pay people as well. And like I was saying earlier, the operational budget is based on an intake of 75 patients initially when we start up. And this total operating budget includes all personnel and the medical supplies required. So these are our plans to achieve our sustainability as an organization, to make sure that we are operating in a functional way as well as continuing to receive patients to keep us in business. So to create enough revenue, each nurse will have to see 4 to 6 patients a day and bill for every service that they provide. That way we ensure we're paid for everything we do and not giving things away. There will also be 2 nurses on call in the evenings and on the weekends that will create additional revenue by billing for after-hour services. We got to bill for all of the services to ensure that payment is received regardless of the source of payment. Continuing education will make certain that best practices are used in the most affordable manner. Teamwork in a successful chain of command will also allow for services to be provided in an organized and timely fashion. Education about hospice in the community will help recruit patients and grow the business. So the way that we're going to talk about hospice in the community is we'll go to different things like nursing conferences, physician conferences, things of that nature. That way we can ensure that people know about our organization and know about the services we provide. That way when they have a patient in the hospital or a patient they see in a clinic, they can call us and say, hey, we have this patient, can you maybe come talk to them and see if they're suitable for your program and see if they want to be part of your program as well. So the next question for this project of forming TeamCare and this hospice organization is how are we going to be innovative and offer something that nobody else offers? So unlike a lot of the hospices, TeamCare, our personnel, we're going to be experts in both hospice care and in end-stage heart failure. Most hospice organizations focus not on anything in particular but serve all kinds of clients. We're going to be very focused, and we know the symptoms that these types of patients have and what to do to treat them the best way possible. TeamCare will focus on current innovative and best practices with an emphasis on patient and family-centered care. TeamCare, we're also going to provide respite care, which means the family members are able to take breaks from caring for their loved one, which can be very helpful because it's a very stressful time when you have a family member that's about to pass away. And TeamCare is going to educate family members because family members will be our eyes and ears between the visits by our staff. We're also going to work with the patient's primary physician to meet the patient's wishes throughout the entire process of their death. So now we're going to talk about the patient outcomes that we want to have as TeamCare for our hospice patients. Unfortunately, the outcome for our patients is going to be death, but we want to make the dying process as pain-free and tolerable as possible. So one of our first goals to improve comfort and quality of life is going to be by measurement of pain management. So when we do the admission assessment, we're going to include the quantity and the quality of the pain that they're experiencing and where it's at and things that may or make it better or worse. We're going to provide adequate pain relief within 48 hours of our initial assessment. Hopefully it will be before then, but there are those cases where sometimes people have some pain that's very difficult to control, so we will work our best to deal with that. We'll have some after-hours personnel to follow up with our new patients and ask about their pain control. So say a person is admitted at 10 o'clock this morning, then maybe about 7 or 8 o'clock that night we'll have one of our after-hour services call and discuss with them to see if their pain regimen is working or if it needs to be changed. We're also going to try to manage other unpleasant symptoms such as their shortness of breath and any swelling they may have in any of their extremities or in their stomach wherever they hold their fluids. We're also going to provide educational materials to the family members and the caregivers just about what to kind of expect during this entire process. We're also going to have surveys for our family members to fill out after their loved one passes away, just to give us some feedback to see what ways can we improve what we're doing, because we always need to look for ways to make things better. Overall, the revenue, though, is going to measure how successful our organization is. So as with any healthcare organization in today's times, we're going to utilize some information technology to complete our documentation. TeamCare will provide all of our nurses with an electronic device to document services at the point of care. So this will be some type of Windows phone. That way it can communicate with some telephone server to go ahead and file our claims as the nurses provide the services. And this just allows for documentation for total reimbursement of every service provided, because as we know, it's much easier to document at the time you do something than to do it later. This also ensures timely delivery of information to each insurance company to make sure that they don't think we're trying to turn in false claims by filing them at a later date. So now I'm just going to tell you a little bit about the policies that affect hospice care. The National Hospice and Palliative Care Organization ensures that clients of hospice have a voice on Capitol Hill and to the people who make decisions about the legislation that affects the payments for hospice care. The two main bills this group are advocating for are the Hospice Evaluation and Legitimate Payment Act of 2013. And this bill is just trying to ensure that providers of hospice care are receiving the pay that they deserve for the services that they provide. Another bill that they are currently working to pass through legislation is the Personalize Your Care Act of 2013. And this just ensures that hospice patients and families are able to have a voice in the types of services that Medicaid and Medicare should cover for hospice patients. The Patient Protection and Affordable Care Act refers little to hospice or palliative care. It allows for accountable care organizations and bundling payments which hospice services can utilize to provide high quality but lower cost medical care for patients on Medicare. The Affordable Care Act also outlines quality measures which hospice organizations must report to CMS as a part of the Hospice Quality Reporting Program. Okay, and that was a very brief overview of the project that our team did for end-of-life care. I hope you enjoyed this presentation. Thank you.